Hi, everybody. I'm here with Lisa Graves, Dr. Lisa Graves, who I have known for a very long time. We're both friends and colleagues. And I've asked Lisa to come and talk with me today about substance use and breastfeeding. I'm going to let Lisa introduce herself so that, because she's got a really long repertoire, extremely knowledgeable, and we'll have some questions to ask from her shortly. Go ahead, Lisa.
Thank you, Carol. As Carol said, I've known Carol for many years. I am currently a professor of family and community medicine at Western Michigan University Homer Stryker MD School of Medicine, which is based in Kalamazoo, Michigan. And I've had an interest in substance use and pregnancy and substance use in women who are postpartum parenting and breastfeeding for probably close to 25 years now.
Yeah. So there's a lot of discussions going on right now related to substance use. In Canada, where I am, we've had legalization of cannabis, and I think in other places around the world, it's also legalized, or there's questions about it. And often we've got to start to realize that we are going to be working with families who may have used have had substance use in the past. They may still be using it, or they may be not using, but there's a history. And often as a health professional, you've got questions that we're wanting to know a little bit about. So just if you could just give me a little bit of information about what work you've been doing in the field, a bit more related to substance use with lactation.
Sure. As a physician, I often have the same sort of questions that many people listening to this have. What are women's thoughts around substance use? And I use women, by the way, because, not to exclude anyone, but more for ease of use. But what are the thoughts around substance use? What are the messages that they're getting? I've been involved in a number of the development of guidelines from the Society of Obstetricians and Gynecologists of Canada around substance use in pregnancy and breastfeeding, and really trying to look at what and how can the literature, either literature that we create or literature that we can access, can actually help us have conversations with individuals about how to make really evidence-informed decisions. And I think that's really critical in this entire conversation. Is my job as a physician is to help parse out the evidence so that when decisions are being made, they're being made grounded in what we know and a full admission about what we don't know.
Mm-hmm. So you've worked with both opioids, and I know recently you've published some articles related to cannabis and breastfeeding. Yeah. Excuse me. So if we're looking at opioids, what would be one of the messages you'd share? Because I want to get onto cannabis. So.
Well, opioids is in some ways a little bit easier because we know that opioids have been around for a long time, and there's actually a fairly reasonable body of literature to support decision making, and there are some excellent guidelines that exist that can really help inform our discussions. And it's really important to understand when talking about substance use in general, there is substance use that is in treatment and recovery, mm-hmm. and then there's substance use that is not. Mm-hmm. And then there's also substance use that would be more occasional. So there's a real continuum to think about. Certainly a lot of my experience has been working with women in opiate addiction treatment programs where we are offering medical treatment for their addiction using buprenorphine, naloxone, or methadone. And I guess one of my take-home messages about thinking about this is that it is never too early in pregnancy to actually start talking about plans for breastfeeding and postpartum. Mm. It is never too early to bring in help, particularly for women who have anxieties about breastfeeding and what that might mean for them and sort of their past history. And so again, there's this opportunity to really plan for potential challenges, both intrinsic, but also based on what's happening within the system. One of the things that the literature clearly points us to is that for women who are doing well in a medical addiction treatment program, there is no medical reason not to support them should they choose to breastfeed. If someone doesn't want to breastfeed, that's another story. But what we do know is that that this should be offered. It should be discussed in a non-judgmental way, and that there is this really interesting opportunity because women, individuals who give birth while using MAT, the infants need to stay in hospital a little bit longer. There's a great opportunity to actually provide support and monitoring to make certain that things go well. And when you think about it, it kind of makes sense for women who are doing well in recovery. Becoming a parent when you're in recovery, and this would apply to anyone, is a normal thing to do. It means that you are starting to a journey of recovery that actually grounds this in what individuals your age are supposed to be doing. And so it can be intensely therapeutic and intensely life-changing in a way that seems even more profound than, you know, having any child should be life-changing. I mean, I don't mean to take away that experience, but for women in recovery, it's often a really phenomenal opportunity. And for others, you know, for parents in recovery, it's really critical. I think the other thing that is important to remember is the fact that there is substantial evidence, and interestingly, much of it comes from work that was done in Vancouver and in Kingston, Ontario, that again, if feasible, having women room in with their babies has been associated again with better outcomes. And what's fascinating to me is the studies looked at not just better outcomes for babies, but better outcomes for the postpartum individual themselves. Yeah. So there's a real tendency in substance use treatment to sometimes forget about the fact that there's an infant and then there's someone else who is equally important. And so the fact that these studies have looked at maternal outcomes improving as well as infant outcomes, I think is a really important nuance to add to any discussion about substance use and breastfeeding. And I think that one of the reasons that I think it's so critical to include this is in discussions around substance use treatment is that when you start talking about breastfeeding, you automatically make certain that the person who's given birth doesn't get forgotten about the moment that the baby is out. And that's, again, just something, again, to punctuate that real need to make certain that we're not so centered on a healthy fetus that we forget that there's someone else who's an important part of this equation.
Yeah, I have such wonderful memories when you were the chief of the methadone clinic in Montreal, and we would work together. And the collaboration there, I have great memories of clients coming back. They did their babies, their children were older, and just we would chat in the corridor, and I'd go, oh yeah, I remember, and they just would say, it made an incredible difference to my life. And it seems something quite simple because that's what we do every day is helping these families. But it is life-changing for so many of them. Mm-hmm. And I think it really is an important role that's played. And I love the fact that you continually, and you've always used the word of non-judgment, because that again is so important with all families, but very much in these areas where there has been such a long history of judgment for these families. Mm-hmm. So I really appreciate that. Now, so I'm going to ask you the question that we've been talking about earlier, and that is, so what is the current evidence? What's the current evidence showing related to cannabis use and lactation? Okay.
So the literature is actually very scant. And so, and actually that has been a challenge that's faced by a lot of research into substance use, because and particularly substance use in pregnancy and lactation, because it's hard to fund. It's, if things are illegal, it's, there are tremendous anxieties about, be recruiting individuals and whether that might actually create problems for them. There are 4-ish studies, and I say ish, looking at, or trying to look at breastfeeding and cannabis. Now, these are actually quite old. One of the first ones is from the 1980s and some in the 1990s. And that takes us to, I think, one important thing to think about when we're talking about cannabis that a lot of people forget about, in that the cannabis that was available in the 70s, 80s, and was available on the street was often around 3%, maybe a little bit more, of THC content. Mm-hmm. And so, again, these studies that were done with THC content. I often say that the cannabis that's been often referred to in, by television comedians, mm-hmm. is much lower THC. So we also know that the cannabis that can be available from dispensaries has been grown to have sometimes a THC content that can approach 25%. Mm. So what we know from literature looking at following children who are exposed to cannabis in utero, again, is there appears to be a dose-response relationship. So again, if studies are done with 3 to 6% cannabis, they may need to be translated differently if women are using a much higher 9, 12, 20, 25% cannabis or THC level. So so that's sort of an important thing to think about these studies, because they really reflect a different percentage of THC. The other challenge with these studies is that they often did not look at infants whose sole exposure to cannabis was during breastfeeding. Mm-hmm. In other words, they didn't separate out infants who were exposed in utero to infants who were exposed postpartum. And a few studies tried to do that, but again, very, very small numbers. Mm-hmm. So you have these studies that sit in the 80s and 90s that reflect a different dose response, a different dose of cannabis, and there's that dose response thing in place. And again, a very poor quality data sets, mm-hmm. so that you don't have a robust group of infants that, for which you can actually say these infants were only exposed mm-hmm. to cannabis and only cannabis during the time that they were being breastfed. The other thing that factors into all of the studies, is that they ended, in my opinion, very early. Mm-hmm. So one of the things that we know about substance use, we know about this about cannabis, we know this about alcohol, is that the impact of some substances isn't necessarily in the first year of life. Mm-hmm. And we know with alcohol and with the 3 longitudinal studies related to cannabis, we know that many of the effects of cannabis don't show up until infants are actually children. Mm-hmm. And those effects of cannabis exposure in utero tend to be things that affect executive function. Mm-hmm. And executive function really comes into play when children are in grade 3, grade 4. We start to make more demands of them. We ask them to be more more the executives of their own life. Yeah. And that's often when those deficits start to appear. And so the fact that the studies looking at cannabis exposure and breastfeeding ended well before that period of time really makes it difficult for us to actually be reassured mm-hmm. that there are no long-term effects with cannabis exposure in pregnancy. So you can probably tell where this conversation is going. And I think that it's really important when I talk to people about this to say we actually don't have great evidence. Mm-hmm. I can lay the studies out in front of you, and I can probably have half of them land on not a good idea to breastfeed and use cannabis, not a great idea, there should be no problem. Mm-hmm. And when that happens for me clinically, I think it's really important for us to say to women, we don't, it's probably prudent to avoid cannabis use when you're breastfeeding. Mm-hmm. It certainly would be prudent, based on understanding dose response, for women to decrease their cannabis use mm-hmm. if they choose to continue while they're breastfeeding. Mm-hmm. The other thing that can be really important for clinicians to understand, as well is that some women are mixing their cannabis, and they mix it in particular with tobacco.
Yeah.
And so again, taking opportunities to actually address not only cannabis use, but also tobacco use and other substance use is also important in this, because again, one of the additional challenges around research and substance use is that many individuals use more than one substance. And so sometimes it can be, again, hard to tease out, what is cannabis. But the current recommendation would be it'd be prudent to avoid cannabis use, and should women continue to use cannabis, the lowest concentration of THC possible, and as much of a reduced production in cannabis as they can during that period of time.
Okay, and so would you also say, because there's many ways of using, right? There's you can be using smoking it, you can vape it, you can dab it, you can take in forms of liquid. Any of those, I'm guessing they may not have even been studied, looking at all the different variations.
Absolutely, the literature again is just not there.
Yeah.
And there are risks and benefits to each modality. One could have said perhaps vaping is better, but now we're getting more data on vaping, particularly with other substances. So again, probably the best advice for in terms of a harm reduction philosophy is to make certain that people know how much they're taking, and again, to be very cognizant of trying to decrease that amount.
Yeah. Okay, then I think that's a great way of doing it. And there's also, so we talk about THC, and I think we had a chat earlier, there is pretty well no research on CBD. And I think CBD seems to be quite, it's being used and being sold as, hey, it's just a great thing to be using type of thing. But we just don't have any information on that either, correct?
Absolutely. The literature on CBD is, again, it's not been done yet.
Yeah. So I think these are really important things that we need to be aware that we just don't have the research that's available. So if I was to ask you like a message that you would have for healthcare professionals who are working with clients that have substance use, or some key messages. I think you've already said many of them, decreasing there, but if say you could just give us a couple of key messages so that can be shared, and that those of us that work in lactation also understand that we are going to be following with clients who may be using or may have a history in the past of using, and how to have that conversation just in a simple way without that judgment feeling that's going. Because again, what our role is to provide information. That the families have got to, they feel good enough or strong enough that they can actually make clearer decisions. And knowing, I think this is probably a little bit important, is that where in Canada it's considered legal, but there is always the concern if a family may be using cannabis and they've told you that there is concerns for the system to come in and potentially take a child away. So I know that's a bit extreme, but so how do you work with all of this? Some key messages, and then I've thrown in a bit of a twister at the end.
So I think, first of all, it's a non-judgmental approach to really, to take in the information and understand that it is far better to know things so that you can plan.
Yeah.
And again, women who have substance use disorders of any kind do worry that they may be required to interact with child protection services in their jurisdiction. And I think, again, it's one of those opportunities to do some planning, to talk about the fact that this may or may not happen. And if it does happen, what are some of the options, and how can we support you in your journey, and what do you want from this? And I think that, again, moving from a model of being very paternalistic about this to encouraging a parent to become an advocate for themselves and to be there in the background supporting them is really a way that we can help move that, that dialogue forward. And again, in jurisdictions where you're allowed to actually have these conversations prior to the birth of an infant, you can start pre-planning about what will this look like and what are some opportunities, particularly in the case where there's a level of instability that would not necessarily allow an infant to be discharged with a parent. So there's a non-judgmental approach, really thinking about planning ahead of time, talking about things like breastfeeding well in advance of birth, because birth gets all muddled up with all sorts of things, and it can, working ahead of time to really think about harm reduction, and that whatever small gains can be made should be celebrated as opportunities and real movement forward, and not to get, and particularly for healthcare providers, not to get disillusioned or disappointed when there's not that perfect outcome that we think we want. Every step and every incremental step is a journey, and being with families as they move along that journey is critical. I think it's really important that we work with our patients, and this actually goes for anyone that I'm looking after, regardless of whether or not they're pregnant or breastfeeding, to really discuss where there is evidence and where there's not evidence, and that and to be very honest about what we don't know, so that again, and I often say to families, in 5 years I may be telling you something very different. And when I can tell you something very different, I'm going to try and be on top of that literature so that we can have a different conversation. But I think a patient population that expects their providers to talk to them about the evidence and use an evidence-informed lens to help make decisions that feel right for them, it will do nothing but improve the system, and will do nothing but improve the health, well-being of families and breastfed infants. So those would be my three messages: non-judgmental, think harm reduction, and and look at the evidence, and a plea to some of my colleagues who are healthcare providers to work on creating that evidence, so that we can again have the types of conversations that are really embedded in telling families, this is what I know is happening.
That's brilliant, and I think they're really, really, really important messages. There's one thing we forgot to ask, is that there are some documents that you've been working on, and like guidelines that have been put out there. So if we're looking for references, if people that are interested to look for some references, where do you think they might be able to find them?
So one of I think the great resources for people are documents that come out of the SOGC, the Society of Obstetricians and Gynecologists of Canada. And I say that because I have been involved in, as the lead author for the alcohol in pregnancy guideline, and I'm currently involved with the development of guidelines that I anticipate will be out in 2021 related to cannabis in pregnancy. And throughout the lifespan, and opiates in pregnancy and throughout the lifespan, and working with a wonderful team of colleagues, interprofessional, looking to see those guidelines come out in 2021. And I think again they will form an excellent resource for providers to look at. There's been a fresh look at the evidence to ground the guidelines, and we are very grateful for the support in many ways that the SOGC has provided to clinicians to actually work on this, and again provide some resources as we try and navigate, particularly in cannabis, a field where the sands are kind of shifting a little bit. And certainly in the Canadian context, as well as in other contexts where in the US where cannabis is no longer illegal, we really need this guidance. There has been a striking absence in the public discourse around cannabis and the impact that it may have in pregnancy and breastfeeding. And the work like the SOGC and work by others in other jurisdictions and other countries have really tried to, again, provide some guidance for providers in an area where we still need to have a lot of work to do.
Thank you so much, Lisa. This has been really, really informative. And as always, I love catching up with you. So thank you for sharing your knowledge. And I really think everybody's going to gain I think the real key message to me has always been we have to take our clients where they're at. We have to provide evidence of what information that we do have. And being non-judgmental is, again, it's such an important part, which we should be doing with all our clients. So thank you so much and stay safe. Okay.
Thank you, Carol.
Take care now. Bye-bye.
Bye.